Hi everyone, welcome to Dr. Deepa's Learning Launch. I am Dr. Deepa and I'm here to discuss with you a very important topic in laboratory quality management, which is interference of hemolysis on the lab results. Most technicians ask me to do a lecture on this, so I am here today with the entire detail. It is when you have a sample which is more pinkish than usual on your serums, or when you have a darker CBC samples that you have a doubt that the sample is hemolyzed. And these days, when the sector is more B2B than B2C, there is an increased quantity of hemolytic samples that would land into you. It is very important to recognize these. So before knowing why you want to reject this, you should also know how does hemolysis affect the lab results, and that would make you automatically reject them with high priority. So without much ado, let's just go ahead. So it is not just one mechanism by which the hemolysis affects the test results. There are four different mechanisms. One is how when there is an intracellular release of substances which are at a higher concentration in the RBC than the surrounding plasma milieu, these test results have an elevated value whenever there is an RBC hemolysis. The second, the RBC has hemoglobin, and this has a spectrophotometric interference to the analytes that are measured by spectrophotometry at around the same wavelength as the RBC, whether it's oxyhemoglobin or carboxyhemoglobin, which is present in the RBC. When there's an interference, it also gets affected spectrophotometrically. Third is chemical interference. Any substance that is measured by chemical reaction and there is an analyte that is present in the RBC which is closely resembles this particular analyte that you're measuring, then there is an interference to that particular chemical reaction and the analyte values change. The fourth is the dilutional effect. If there are concentration of substances which are at a lower concentration in the RBC than that of the plasma milieu, then there's a dilutional effect and a false lowering of these analytes whenever you're measuring a grossly hemolytic sample. So let's take each one of these importantly. First is the intracellular release. So as we all spoke about, the RBC contains several analytes at a concentration much higher than the surrounding plasma milieu. So when hemolysis occurs, these are released at a higher concentration, and these components that are inside the extracellular fluid are measured at a higher value. Some of these falsely elevated values include those of potassium, LDH, AST, magnesium, and phosphorus. So whenever you have a hemolytic sample, these concentration will be at a significantly higher level than the routine extracellular fluid values. So notable interference occur even at very low concentration, very low hemolytic interference also. You can have a very notable increase on any of these parameters. The clinical insight is, does this really matter? Yes, it does. It is clinically very dangerous, especially even mild hemolysis can cause a significant error in potassium, and a false hyperkalemia value that is released by the lab professional can cause an unwanted treatment. This is more important in patients who are on IV fluids and who are on renal failures. Whenever you are doing a follow-up value of potassium, it's very important that your lab releases the correct value of potassium. Otherwise, it can cause a wrong treatment and an unnecessary treatment for the patient. The next is the spectrophotometric interference. When biochemical parameters are measured by spectrophotometry, a selected wavelength is what an analyte is measured at. So there can be an overlap of the absorption spectrum with hemoglobin. As a result, the hemolysis can interfere with the acid result, which to an extent where the interference is certainly that is dependent on the concentration of hemolysis, but it can interfere to a significant level, especially in a high hemolytic sample. Both oxyhemoglobin and deoxyhemoglobins usually get absorbed at a peak of around 415 nanometers. To be precise, the deoxyhemoglobin usually absorbs somewhere between 540 to 589 nanometers, and the oxyhemoglobin somewhere between 320 to 450 nanometers. So whenever there's an analyte which is measured by spectrophotometric measurements at this range, then there is an interference with the result of that particular analyte, which closely resembles this wavelength. Some example is lipase, albumin, and GGT. Whenever lipase, albumin, and GGT, which is measured a little above these wavelengths, these also can show a falsely elevated result because the instrument is wrongly measuring the hemoglobin and not these analytes. So values of lipase, albumin, and GGT can be falsely elevated in a hemolytic sample, and that is because of spectrophotometric interference with hemoglobin that falls around the same nanometer wavelength. The next effect is very important, which is a chemical interference. If you're measuring a particular analyte on the basis of a chemical reaction and there is a close analyte which is released by the decaying RBCs due to hemolysis, then there is an elevation of that particular analyte. Some of the examples include adenylate kinase that is released from the RBC. So this adenylate kinase that is released in RBC closely mimics the chemical reaction by which creatine kinase is measured. So whenever the patient is coming to you with a creatine kinase for a test and you have a hemolytic sample, then this creatine kinase level will be falsely elevated. And that is basically because the RBC has released adenylate kinase and that closely mimics creatine kinase, causing a false elevation of creatine kinase. So even those reports should not be released. The most important another thing is whenever you ask a patient or you ask a technician on what does hemolysis do, they would only pick up a few things and say LDH and potassium is elevated. They usually forget what is dilutionally reduced also. There are certain analytes which are at a lower concentration in the RBC compared to the plasma surrounding it, and these analytes are falsely lowered. That is because of the dilutional effect of the milieu of the RBC that is exited into the extracellular fluid. Some of these analytes include glucose, sodium, and chloride. So whenever there is hemolysis, in the same scenario where the potassium is raised, glucose, sodium, and chloride are falsely lowered. That is because of a dilutional effect. So that also needs to be kept in mind. What is the clinical importance of sodium? Do I really care if my report comes out with a little low sodium? You need to understand that your report can be very, very important to a patient in ICU or a patient who is on IV fluids or a patient who is being monitored for, let's say, refractory hypernatremia or hyponatremia. For any of these patients, your level of sodium that you're giving out in each of the reports is very, very critical. The therapeutic range of sodium is also very, very narrow. Somewhere between 135 to 145 millimoles per liter is a narrow therapeutic range where you want the sodium to be. Anything that falls short of this or falls above this can have the patient have really bad symptoms. So when you're releasing a report which is giving you a falsely low sodium, and God forbid if there is hypernatremia in the patient, then the treatment really goes topsy-turvy. So you need to be very, very careful when you're releasing even reports of sodium, even in mild hemolytic cases. So that is why it is very, very important, because it would need to unnecessary further investigations. For example, there can be a fluid restriction in case you've given a very low sodium value, which was unnecessary for the patient, and that can cause very bad effects on a patient who's already moribund and is on IV fluids or in an ICU. So it is better to raise a suspicion of a pre-analytical error, communicate with the clinician in that scenario, tell him that the sample that had come to you is mildly hemolytic and you're not very sure about the sodium that is given out by the machine and you want a fresh sample. Don't release that report. Next, we move on to what else can a hemolytic sample affect. It is not a niche problem. It is not only the biochemical tests that are affected. Hemolysis affects your ABG reporting. It affects the CBC parameters. To be specific, it increases the hemoglobin MCHC, as you all know. And it can also change the coagulation profiles, and even immunoassays are affected by hemolysis. So it is beyond biochemistry. It's a universal laboratory problem and it's not a niche problem. So where do you curb it? You have to obviously understand that this is a usual pre-analytical error. If things like intracellular hemolysis or extracellular hemolysis, which the patient is going through, if that is happening, that is something that is not in your hands. And in such cases where you know that the patient is undergoing hemolysis, let's say due to a heart valve or because of any other type of hemolysis where it is unavoidable, you still want to give out the report. In such cases, you should pick up the phone, tell the clinician that hemolysis can cause interference in these parameters, and you need to look at these with caution. That's the exact same list that I spoke to you about a while ago. So in case of an unavoidable hemolysis that is happening within the patient and you have nothing to do with it, it is unavoidable. You might have to release a report, but yes, do mention in the bottom that the sample was hemolyzed, and you need to look at the report with caution. But in any case, if the hemolysis is because of a pre-analytical error, it is absolutely avoidable. If it is a pre-analytical error, there are multiple areas where you need to look at where can you stop this. Suppose there is a particular referral lab that is giving you multiple samples, and you see that the amount of hemolytic sample that comes from that to your CRL is more. You should always analyze that. Stop it at the source. If it is the patient problem, fine, you cannot change it. Patient is undergoing hemolysis, you can't help it. There, you have to put a comment saying, read these analytes which can have possible interference because of hemolysis with care. pick up, talk to the clinician, tell him that this is unavoidable, and these are the test results that you have to look at with caution. But let's look at what all can you prevent pre-analytically, and which is there in your hands, which is if you know that the sample is wrongly collected, what do you do? The first is avoid IV line draws. Mandatory rule. I would never allow a nurse to pick up a sample from the IV line. And if it is something like there are no other veins available and you have to, God forbid, take it only from an IV line, and you just have one vein in the whole patient is edematous, and you have just one line. In that case, there are two alternatives. One, when you're fixing the IV line, just allow 1 or 2 drops of blood to drop and take the sample immediately from that IV line before you put any IV fluid or any medication or any fluid for that matter, which can change the test results. As soon as you knock the vein, take the sample, waste 1 or 2 drops, and then take the next into your vacutainer tube. If there is only one line available and you have no other vein available to take out the sample, try a central line. And if you take a central line sample also, waste 5 to 10 ml of blood from it and then collect the sample from it. So that's the other workaround. But ideally, for a normal patient, do not for a normal conscious patient in whom you have multiple veins are available other than the one in which the IV line is, do not take the sample from the IV line at all times. One, that is very important, and that is the strongest evidence of interference and hemolysis. So switching to direct venipuncture reduces hemolysis by up to 84%, and that is documented in many studies. So just a switch of not picking up from the IV line and taking it from a direct venipuncture can reduce the chances of hemolysis by 84%. And this is a study done on the ICU patients. And I would still like to believe, if somebody asked me, I would say no IV line at all. So that is the very strongest evidence, and there is somewhere you can avoid a hemolytic sample. Second, does the needle matter? Yes. The size of the needle definitely matters. The smaller the needle, the more is the hemolysis, because the RBC is definitely something that does milieu through narrow passages. But if it is too small, then it will rupture. Usually there is a recommendation that you have to use a 20 to 22 gauge needle, and a little bigger than that also is absolutely fine. Your vacutainer needles are slightly bigger than that, it is absolutely good. But if you have to take, then you do with a needle, with a syringe, then use only 20 to 22 gauge, and do not go be smaller than that. The smaller the needle, the chance of hemolysis is much more higher. Whenever there is a small needle, the RBC has to maneuver through a small passage, and that causes shear stress and causes increased hemolysis. So the needle size also matters. Then next, tourniquet time. Tourniquet time is very important, because I have seen, even when I shouldn't be really revealing such things to you, but yes, I have seen certain situations where the tourniquet is tied to the patient, and suddenly the lab technician gets a call, he holds the phone and then leaves the tourniquet in for longer than 1 minute and then draws the sample. Do not tie the tourniquet on the patient unless you are sure you're going to take a prick. Do not tie the tourniquet. If there is a patient who has told you that he needs 5 tests and he's not sure about it, please talk to my clinician and find out if I need anything more. Then remove the tourniquet before you draw the sample. Remove the tourniquet, reapply the tourniquet when he's ready to take the prick only. And the tourniquet time to the prick time should be less than 1 minute at all times. The shorter, the better. So keep the tourniquet tying time at less than 1 minute at all times, and a prolonged use causes both hemoconcentration and hemolysis because of pressure that you've applied. Another important thing is site selection. Site selection is very critical for compromised areas, because if the site selection is wrong, there is poor flow. If you're actually targeting a very small vessel, let's say on the back of my hand there's a very tiny vessel, you're using a small bore needle and trying to prick a very small vein from my hand, then definitely there'll be hemolysis. And another thing is, if there is a patient who has undergone burns, if there's a patient who has undergone, let's say, has anasarca all over and there's too much of edema, those areas you have to avoid. Select a place in the patient where there's no fistula, where there's no injury, where there's no infection, no edema, and no burns. So make sure that the area that you're selecting is clean, clear, good visibility of the vein, and then take a prick. Whenever you have whenever the people ask you which is the best vein to be selected in a normal walking patient, then the antecubital fossa is by far the best, because they have stable veins of a good caliber. There is a better flow, and that significantly lowers the risk of hemolysis. The next is another very important thing that most technicians miss is alcohol and then dry. Especially post-COVID times, when sterilium is available and good concentration of alcohol is available, which is above 70% isopropyl alcohol, people miss the fact that alcohol also is a chemical interference, and it can interfere and hemolyze the sample. So whenever you're applying alcohol on the patient for the sake of sanitation purposes before you take out the sample, then very important thing is to wait for a couple of seconds, wait for 30 seconds till the alcohol dries out on its own. And only when the area is dry, then take a prick, because otherwise the alcohol can cause chemical hemolysis of the blood that you're drawing. Even if it is minimal, yes, it does interfere. So the alcohol does RBC membrane damage, as we all know. So whenever you're applying alcohol to sanitize a particular area, make sure that you wait for 30 seconds, let the entire area dry, and then take a prick. That is also very, very important. Another very important thing in to avoid a pre-analytical error is how you transfer a sample. Suppose you have a vacuum that is given to you, it's filled up to the volume that is supposed to be filled, and you have to take it to two labs. You just want to put it in another empty vacuum. What do? There are technicians or there are staff who might use who you might use a needle to pick up the sample, a narrow bore needle to pick up the sample from this vacuum to that vacuum. Don't do that. As far as possible, using a vacuum-based closed system to transfer the sample from one unit to other unit is always ideal. And if it is unavoidable, use a gentle syringe transfer without the needle. That is also fine. But forceful syringe usage with the needle, which can damage or hemolyze, or an excessive movement during transfer, all these should be avoided to avoid hemolysis. So proper transfer technique also has to be used. Next very important thing is the tube filling. Most of the vacuolators have a black mark on top, which says the appropriate volume of blood versus the amount of reagent that is there in the particular vacuum, which whether it's an EDTA or fluoride or any of the what have you. If that particular area is filled till the area where it's supposed to be filled, then you are safe. Underfilling usually causes an improper ratio of the blood to additive of the vacuum, and which can cause hemolysis or an erroneous test result. So that is also very important that you monitor how the tube is filled. The next is handling and transport. A perfect collection but a poor handling also can cause very bad hemolysis. For example, if the technician if the phlebotomist who's supposed to pick up the sample has done a fantastic job, he has put the tourniquet for less than 1 minute, he has taken the antecubital fossa, he waited till the alcohol dried, he's used a white bore needle, a beautiful vacuum cleaner, filled the vacuum cleaner till where it is. But then after that, he forgets that he's not supposed to over shake it. Suppose he forgets that the transport guy has to be instructed that it has to be smoothly transported, avoiding too much of movement during transport, or it is transported at a higher temperature. What's the point of drawing it perfectly well? When it reaches the lab, it's still hemolyzed. So that's why it is very important that the handling and transport also be taken very good care of. For example, if it is a mixing, we always tell them to invert and evert a sample whenever you're doing, very softly, like it very, very smoothly, very, very slowly, up to 5 to 10 times and not beyond that. Or as a figure of eight, when it's an EDTA sample or something, we tell them figure of eight, but very smoothly. Never be over enthusiastic and shake it like you are shaking Pringles. So please don't do that. So there is clearly evidence that mechanical destruction of RBC can happen when there is an over enthusiastic shake of the vacuum cleaner. So gentle inversion eversion and ensures that there is proper mixing of the sample with the additive that is there in the vacuum cleaner, and you can always make sure that the hemolysis doesn't happen. Transport care is very, very important. First, to avoid physical trauma, rough handling during transport, putting it into mechanical stress during transport, especially in emergency setups, can always damage the RBCs and cause hemolysis. So whenever there's high workload also, speed should never compromise the quality of the reports that you give. You want to give out the reports in 2 hours, it's fine, but make sure that the report is accurate. What is more important is that you give out the correct report and not how fast you give it. So that is very, very important. Transport care also includes the temperature at which the sample has to come. For routines, it is always 2 to 8 degrees that you want the sample to reach the laboratory. For coagulation, -80, -20, in case you're doing the same day, is recommended. Make sure that the temperature is and the cold chain is maintained right from the time of drawing the sample till it reaches the testing area. So that is also very mandatory, and that is also something you have to take care in the transport. The newer pneumatic tube systems have come to play in larger hospitals. It is a boon to the nursing faculty, where the nurses don't have to hold the sample and run around all the different areas in the building. They don't have to go up and down with one sample. They don't have to run from the ICU to the lab every time. Definitely, it's a boon for the nursing and the physicians, definitely, but it has to be maintained well by the laboratory. The pneumatic systems are efficient but risky. They can cause hemolysis. So, very important thing that the laboratory head or the head of the healthcare unit has to make sure that there is appropriate cushioning. Wherever the sample of the pneumatic tube system is landing, the cushioning has to be perfect. You just can't have a fast commute and forced landing at the place that is coming down to. So you should have a accurate cushioning. There should be a vertical positioning, and the vibration at all times should be reduced in the pneumatic testing systems. And all of these have to be included in the quality management of that particular hospital to have less hemolysis. So PTS, definitely faster transport, but you have to make sure there is good cushioning, good vertical positioning, and no vibration. Another thing, I already mentioned this, but this is temperature control. Prevent extreme heat, extreme cold, because they just like I told you, it is 2 to 8. Don't be overzealous on the freezing also. You don't want the routine sample to be completely clotted, completely frozen. Freeze thawing also can cause hemolysis. So the temperature 2 to 8 should be packed in a way that there is no direct contact between the sample and the ice. There should be walling of the ice on all surfaces, and it should not be in a way that it completely freezes. You have to make sure it is at 2 to 8 degrees, but direct contact with ice should not happen. So even extreme cold also is a problem, as is extreme heat. So this temperature level that has been set in has to be monitored right through the transport, and that is how you maintain the integrity of the RBC and avoid hemolysis. Laboratory quality control, very, very important for hemolysis, curbing hemolysis, which is the largest pre-analytical error. So laboratory quality controls includes detection, monitoring, and policy implementation. As a laboratory leader like me, these are the areas where I would put my foot in and say, look, this much is the amount of hemolysis I'm getting from this particular transport area. I need to look at the detection. I need to make sure my technicians can detect it. I need to make sure my instruments are doing well in detecting the H score. I need to look at the monitoring. How am I monitoring the rejections? I need to look at the policy implementation. So that is where my role as a lab director comes. So one thing is automatic detection. See, now there are multiple laboratories which work at different scenarios. There are some areas that are cloudier, lesser lighting, some areas which have beautiful lightings, well lit laboratories, but some that fall short of it. You might have to collect and process sample with daylight, which is subject to change throughout the day. So do you actually look at the serum, and are you able to detect even mild hemolysis? Very subjective, right? I can see, someone else cannot see. So when such subjectivity sets in into some parameter that is so important, that's when things get detrimental for any laboratory. So let's just eliminate the subjectivity. So most of the high-end instruments now have an automated H index analysis. So that can be set in either by having an instrument dedicated for detecting the HIL index, or you have even modern machines which pick up even when you're running the sample in the machine. So one is you have an objective measurement, no subjectivity there. Second is a rapid detection, which is not subject to change of manpower, and a standardized reporting. Every time the machine will tell you hemolysis at a particular cutoff, and it will never miss it. So that is where automated detection is something that is a thumbs up from me, and definitely an automated detection for hemolysis is something that most laboratories should have. Next is training the staff. You should have a very good training program, which is a backbone for all the laboratories. The training structured usual programs are 30, 60-day structured programs, which you have to make, which should be on the basis of standard techniques. You should have the checklist kept for them to detect hemolysis, for them to understand the analytes that can come abnormal. And in case there's an abnormal analyte, you need to look back at the sample, whether you missed a hemolytic sample, and also a sustained quality and competency. If I always swear by the word that competency must be monitored and it should not be assumed. You can have even the best of the technical staff making a mistake because of increased workload. It is not uncommon. So competency is something that is routine. It has to be done according to the NABL protocols. It's done once in 6 months. So competency is a daily thing. As a laboratory director, you need to look at each of the staff, have a watchful eye on any of your staff every single day. And whenever there is these abnormalities where a staff has missed the hemolytic sample and you have an abnormal result in your bucket, and then you go back in the instrument and see there's a H index flagging, then it is also important that you get the technician back to your desk, tell him what hemolysis can do, tell him how it affects your test report, and then train him again. Do his competency assessment after the training, do his competency assessment of one month later to make sure that he's still following the rules that are set up by you. And also make sure all the checklists are available with them as to what are all the rejection criteria. Then another system is the monitoring system. There needs to be a continuous monitoring on any of these. Track hemolysis rates per laboratory that is sending you, and identify the high risk rate. Suppose you have, let's say, a B2B sector where there is samples that are transported from a long distance and it's coming to you after a long time, and you notice that these are the samples that are getting rejected repeatedly because of hemolysis, and the percentage is gone way above 10%. Then in that case, you need to talk back to the person, make sure that the transport happens quickly, rearrange your transport, rearrange your staff in a way that the commute time is reduced or the temperature chain is maintained. Look into that, research into the cause, make a root cause analysis, come to a point where you know what the reason is, and make sure that the monitoring systems are in place. So these are things where laboratory leadership have a role to play. And then very important thing is also that you need to have a policy framework. Not all hemolyzed samples need to be rejected. The decision depends on the degree of hemolysis, the analyte that is affected. So you should have a very clear SOP regarding what exactly are the analytes that are interfered with. A very minimal hemolysis are good to go, and you should have a very clear communication with the clinician, because you have to know what is happening to the patient and you have to try to get a fresh sample. Next is also that you need to have specialized tubes. There are tubes that are available now which are called low vacuum tubes, which do not over enthusiastically, do not agitate the sample, do not suck the sample out of the patient. So these low vacuum tubes are readily available, slightly a little more costly than the regular vacutainers, but these reduce the blood flow velocity when they are filling from the patient into the vacutainer. So it is ideal for both the fragile vein patient, and it is also ideal for patients who are prone to hemolysis. So very important thing is that whenever there is shear stress, there are problems with the hemolysis. That is where you need to take care. Then also very important is that most hemolysis is very much preventable. So focus on the areas that I have spoken about. So make sure that the collection technique is right, make sure that the handling is right, make sure that your quality systems are in place, because prevention is what gives good patient safety and cost reduction. So quality is a culture. It is not something that is done. So you are doing it right when there are fewer repeat samples, when there is faster diagnosis, and when there is better patient care. Thank you so much for your patient listening. This is Dr. Deepa signing off. And as you know, I am available on my website, which is www.drdeepaslearninglaunch.com. And we are also available in all the social media platforms that have been there for your use. I hope you like this video. Stay tuned to Dr. Deepa's Learning Launch on YouTube, Instagram, Facebook, Telegram, or Twitter. Bye-bye.